Shall we start, sir?
Yes, madam. Start recording.
Is my PPT visible?
Yes, yes.
Okay.
Dr. Krishna.
So today I'll be discussing about cranial nerves. I want this session to be a little bit interactive. So if I ask questions, students should be ready to answer. I will start with extraocular, that is third, fourth, and sixth cranial nerves together. So,
Yeah, go ahead.
hello.
Yeah, madam. You can start.
Is the voice breaking, sir?
Sometimes.
But that's only
Hello.
for English. Remaining is very clear. You can go ahead, madam.
Is the voice breaking?
No, madam. Your voice is
Oh.
very clear. It's
Now
visible.
it is clear.
Okay. Okay. So we'll
Yeah.
start with the third, fourth, sixth cranial nerves. So third, fourth, sixth cranial nerves, they innervate the extraocular muscles. So we all know the extraocular muscles, the four recti, they arise from a common structure in orbital apex called as annulus of Zinn. The
Can you
annulus is
start
a
your
thickening of,
slideshow?
sorry?
Slideshow.
Yeah. So annulus is a thickening of periosteum which forms a circular tendon, and it is pierced by optic nerve and the central retinal artery, and cranial nerve third and sixth and recti arise from its body. The four recti muscle, they insert into the sclera 5 to 7 millimeter posterior to the limbus. Okay, and the superior and inferior oblique insert into the globe at an angle about 30 degree from medial to lateral. Superior and inferior obliqui, they insert into the globe at an angle of 30 degree from medial to lateral. The obliqui, they insert more posteriorly into the globe. Superior oblique pulls back the eye up. Superior oblique, it pulls the eye up, producing back of the eye up. So it produces a down gaze. And inferior oblique pulls the back of the eye down, producing the up gaze. Just remember, superior oblique causes down gaze and inferior oblique causes up gaze, or elevation of the eye rather than saying a gaze. Superior and inferior recti, they are also lying in the orbit, they insert into the globe. Okay, and superior and inferior oblique insert into the globe about 30 degrees from medial to lateral angles. So we all know the functions of extraocular muscles. We should remember that recti are best checked in abduction, and the oblique are best checked in adduction. That means the maximum function of that muscle of recti is in abduction, whereas oblique effects in the adducted eye. So lateral rectus and medial rectus, they are responsible for the horizontal eye movements. The inferior oblique and superior rectus, they cause elevation, and superior oblique and inferior rectus, they cause depression. So this is the actions of the extraocular muscles. Medial rectus primary action is adduction. Lateral rectus primary action is abduction. Superior rectus primary action is elevation. Inferior rectus primary action is depression. Whereas primary action of oblique eye, that is superior oblique, is intorsion. Inferior oblique is extorsion. And secondary action of the oblique eye, that is superior oblique, is depression, and inferior oblique is elevation. Superior oblique causes depression and inferior oblique causes elevation. So this is the yoke muscle pair, that is medial rectus with the contralateral lateral rectus, superior rectus with the inferior oblique, which cause elevation, inferior rectus with the superior oblique cause depression. So this is about third nerve. third nerve has somatic efferent, third nerve nucleus that is causes somatic efferent supplying the ocular muscles, and general visceral efferent which is coming from the Edinger-Westphal nucleus. It supplies the sphincter pupillae. The most important part of the third nerve when we talk about localization is the arrangement of third nerve nuclei. Okay, so in the center there is a central chordate nucleus and Edinger-Westphal nucleus. They are in the midline. Next to it are superior rectus nuclei, and lateral most are inferior rectus, inferior oblique, and medial rectus nuclei. So this arrangement is very important because if there is a infarction involving this area, that is central caudal nucleus, then because central caudal nucleus supplies the bilateral levator palpebrae superioris. Okay, and even the superior rectus, it is contralateral, and these are also contralateral. So the third nerve has two divisions, that is superior division. It supplies the levator palpebrae superioris and superior rectus muscle, and inferior division supplies rest of the medial, inferior recti, inferior oblique, and also the pupil. So pupillary fibers are coming from the inferior division, whereas levator palpebrae superioris and superior rectus, these only two muscles by the superior division. And lateral subnucleus, that is this is the lateral subnucleus. Lateral subnucleus innervates inferior rectus, inferior oblique, and medial rectus. It is innervating the inferior oblique in medial and inferior recti. That is inferior division of the third cranial along with the pupil. Superior rectus is innervated by the contralateral medial rectus. Contralateral medial subnucleus. This contralateral this is the medial subnucleus, which is contralateral, supplies the superior rectus of the opposite side. In inferior rectus, inferior oblique, and medial rectus, through the inferior division, they supply the ipsilateral, inferior oblique, medial recti, and inferior recti. Okay. And the central caudal nucleus, it supplies bilateral levator palpebrae superioris. So whenever there is a third nerve nuclear palsy, you can get bilateral ptosis because of involvement of levator palpebrae superioris supplied by the central caudal nucleus. And also superior rectus weakness can happen in the contralateral eye if there is a nuclear third nerve involvement because of this involvement of superior rectus nuclei. So that is single midline structure, central caudal nucleus supplies both the levator palpebrae superioris on both sides. Edinger-Westphal are also part of the parasympathetic innervation of the third nerve. And so basically, let us talk about the anatomy of the third nerve. So anatomy is like it is originating from the nuclear complex, which is situated in the midbrain, and it conveys motor fibers to the extraocular muscle plus parasympathetic fibers to the pupil and the ciliary body. The nuclear centers, they are situated in the periaqueductal gray matter just anterior to the aqueduct of Sylvius at the level of superior colliculus. Each oculomotor nucleus consists of multiple subnuclei, which we discussed. Multiple subnuclei, central ones are central caudal nucleus and Edinger-Westphal nucleus. Next to it are superior rectus medial subnucleus. And next to it are lateral subnucleus, which has innervation for the ipsilateral, inferior rectus, inferior oblique, and medial rectus. Superior rectus in a medial subnucleus is contralateral to the opposite side superior rectus, whereas central caudal nucleus is for bilateral levator palpebrae superioris. So these subnuclei, they are just anterior to the periaqueductal gray matter. Nerve passes through the red, this is the red nucleus, so nerve passes through the red nucleus, emerges ventrally in the lateral body, this is the interpeduncular fossa. So it comes out at the lateral border of the interpeduncular fossa and passing through the subarachnoid space between the superior cerebral artery and posterior cerebral artery, and it is exactly parallel to the PCOM. So whenever there is a PCOM aneurysm, you can have third nerve involvement in the subarachnoid space. And then it passes through the lateral wall of cavern. You can see here, then it passes to this is the cavernous and lateral wall of cavernous sinus. The third nerve passes through the lateral wall of cavernous sinus along with other cranial nerve. So in lateral wall of cavernous sinus, there is association with the internal carotid artery. Then there is a sympathetic plexus, fourth nerve, fifth nerve, that is V1 and V2 division of fifth nerve. So once it passes through the lateral wall of cavernous sinus, it divides into superior and inferior divisions. And they both pass through the superior orbital fissure, entering into the orbit. And then it's along in the inferior division, there are fibers to the pupil, that is sphincter pupillae. So now we have understood the anatomy. There is at the level of superior colliculus, third nerve nucleus is situated, which has many subnuclei. Okay, and the nerve comes out and passes through the red nucleus and comes out at the lateral wall of the interpedunculaire fossa between the superior cerebral and posterior cerebral artery and next to PCOM. Then it enters into the lateral wall of cavernous sinus, divided into further it goes ahead and it divides into two divisions, superior and inferior division, and both of them pass through the superior orbital fissure to supply. And superior division has only the fibers for the levator palpebrae superioris and superior rectus, whereas inferior division all other muscles along with the pupil. Okay. So whenever there is a third nerve palsy, you will have involvement of, there will be difficulty in adducting the left. Suppose, for example, right third nerve is there. So right eye adduction, right eye elevation, right eye depression. There can be complete ptosis and there can be enlarged pupil, which is non-reactive because of the third nerve involvement. Now, pupillary fibers, they are superficial to the nerve. That's why they are prone to compression. So in diabetic diabetic third nerve, it is intrinsic microvascular ischemia. Hence, the pupillary fibers, which are superficial, they are spared. So this is the most important chart when we talk about the localization of third nerve. So we have understood the anatomy of third nerve nuclei. The medialmost, the centralmost are central caudal nucleus and Edinger-Westphal nucleus, which are going to innervate both sides. So it is going to innervate both, the central caudal nucleus is going to innervate both levator palpebrae superioris here, Edinger-Westphal also both side pupils. Then next to it is superior rectus, which is medial subnucleus, going to supply the contralateral superior rectus muscle. And lateral subnucleus is inferior rectus, inferior oblique, and medial rectus. And from there, the third nerve comes out from the nuclei. That third nerve comes out. This area is called as fascicular part of the third nerve. This is the fascicular division of the third nerve. So the lesions can be here in the nuclear division. Lesions can be here in the fascicular division. Once it leaves the brainstem, that is, once it leaves the midbrain, this area is called as cisternal segment, where it lies in the subarachnoid space. Then it enters into the lateral wall of cavernous sinus. That is the cavernous part of the third nerve. Then it comes out and divides into two divisions, superior and inferior, and both of them enter into the superior orbital fissure and finally into the orbit. So we will have localization for all of this. Okay, so if there is third nerve nucleus involvement, as we discussed, if there is a third nerve nucleus involvement, we can expect that there is a ipsilateral complete third nerve palsy. There can be also ptosis on the other side and superior rectus involvement on the other side. So because central caudal nucleus is involved, you can have bilateral ptosis and you can have superior rectus palsy on the other side. If it is subnuclear involvement, each subnuclear can get affected like just superior rectus, but it is very rare. Isolated levator palpebrae subnuclear, that is central caudal nucleus, can get affected, giving rise to bilateral ptosis. This is about nuclear. So nuclear third nerve can have bilateral ptosis and other side superior rectus palsy can also happen. If you talk about third nerve fasciculus, which I discussed, fascicular division is within the brainstem itself. So till the time it is in the brainstem, leaving the nucleus, it is fascicular division. So if it is fascicular involvement, then you can have complete third nerve with pupil involvement. If it is paramedian mesencephalon part of the third nerve involved, fasciculus, then there can be plus minus syndrome. What is plus minus syndrome? So ipsilateral ptosis and contralateral eyelid retraction. This happens because of the involvement of third nerve fascicular division within the paramedian midbrain. Okay, so plus minus syndrome is ipsilateral ptosis and contralateral eyelid retraction. Suppose the fascicular red nucleus and superior cerebellar peduncle is involved. That is a Claude syndrome. That is ipsilateral third nerve with contralateral ataxia or tremors. So if, for example, here it is affected, third nerve with red nucleus and superior cerebellar peduncle. So you will get ipsilateral third nerve. Okay, then you can get tremors contralaterally and contralateral ataxia also can happen. That is Claude syndrome. If there is fascicular division involvement and the peduncle, then third nerve and contralateral hemiparesis can be there. Then it's third nerve fasciculus and only red nerve or substantia nigra. It is third nerve with contralateral chorea. That is Benedict syndrome. So there is a difference between the Claude and Benedict syndrome. Third nerve is everybody's clear. Third nerve is Weber is everybody clear. That is third nerve with contralateral hemiparesis is Weber's. But third nerve with contralateral chorea because of involvement of red nucleus over here. Third nerve and red nucleus. That is going to give rise to Benedict syndrome. That is third nerve and contralateral chorea. And if there is third nerve and contralateral ataxia, that is Claude syndrome because of involvement of superior cerebellar peduncle. Then once the nerve leaves the brainstem, it comes into the subarachnoid space. Then it can give rise to, because of the involvement of, for example, meningitis, subarachnoid space hemorrhage, that is subarachnoid hemorrhage. That can give rise to involvement of third nerve within the subarachnoid space, giving rise to complete third nerve palsy with pupillar involvement. Then once the nerve comes into the lateral wall of cavernous sinus, so there can be involvement of third nerve, but what will be the pupil? Pupil can be mid-size. Why? Because of third nerve in the lateral wall of cavernous sinus, third nerve is also along with the, there is also a nearby sympathetic plexus situated. So sympathetic involvement will give rise to dilatation of the pupil. Third nerve involvement will give rise to dilatation of the pupil, but sympathetic involvement will give rise to smaller pupil. So it becomes a mid-sized pupil or a smaller pupil than what we expect in the third nerve. Okay, so this is one location which will help differentiate. This is one point which will help differentiate cavernous from the superior orbital fissure. So superior orbital fissure also multiple cranial nerves will get affected. Even in cavernous sinus, multiple cranial nerves can get affected. But the difference between the two is in the cavernous sinus third nerve, the pupil will be small or the mid-sized pupil. Whereas in the superior orbital fissure, it will be a big pupil because there is no opposed action by the Horner syndrome. Okay, and once it comes into the orbit, it is already divided into superior and inferior branch. So involvement of superior branch will give rise to only ptosis on one side and impairment of the elevation of the eye. That is because of involvement of superior rectus. If there is only inferior branch getting involved, then rest of all other eye movements will get affected along with pupil. So this is the most important part of actually third nerve localization. So I will be discussing similar way all other cranial nerves, that is anatomy, and in short, where will you localize the third nerve? Can anybody answer this? So can anybody answer where would be the localization? You have a complete third nerve. Sir, can they speak or it will just answered on the...
If anybody want to comment, they can unmute themselves and they can speak for.
Yeah, somebody is trying to answer here.
Yeah, Dr.
So it's a
Ashwini
left.
and Dr.
Yeah,
Suranjana, you
can you
can
tell?
unmute and
Yes, ma'am, I would like to answer. So, ma'am, here
Yeah,
it looks patient has complete third nerve involvement, and then we
yeah.
showed the fifth cranial nerve examination by showing sensation all along the face, and
Hmm.
plus will seem to be mid dilated in the affected eye.
Yeah, yeah.
So that is why it would be third plus fifth with mid dilated pupil. So cavernous sinus would be
Yes.
localization.
So this is a classical cavernous sinus syndrome where the pupil is mid dilated, not fully dilated, which we expect in the isolated, which we expect in a third nerve, which is not opposed by the Horner syndrome. Okay. So this was the patient with left cavernous sinus. This patient had a fungal mucormycosis. So this cavernous sinus involvement was there because of which was causing the third nerve and V1, V2 distribution involvement. Can anybody answer this one? Yeah, anybody? So this patient has a complete third nerve involvement and there is a full pupillary dilatation. So where do you, and there is no other cranial nerve involvement. So where do, and there are no long tract signs also. So where do you think this will be localization? See, that is what I'm trying to say. The fascicular division is within the brainstem itself. So if there is involvement of third nerve within the brainstem, that is fascicular division, you will get brainstem or long tract signs. This is isolated third nerve which is not causing any other involvement, and there are no long tracts related. There are no cranial involvement. Again, I'm telling.
Subarachnoid space.
Yeah. Yeah, so the localization will be cisternal segment, that is subarachnoid space. Because in superior orbital fissure or in the cavernous sinus, you will get multiple cranial nerves. In cavernous sinus, the pupil will be mid-sized, and in the superior orbital fissure, the pupil will be large size. There are no long tract sign in this patient. Otherwise, if there were long tract signs along with third nerve, we would have thought of fascicular division. Fascicular means within the brainstem. Once it leaves the brainstem, it becomes a cisternal or subarachnoid segment of third nerve. Okay. So this patient had a tubercular meningitis and the third nerve got caught within the cisternal segment. So I'll go to next cranial nerve, that is trochlear nerve. It arises from the nucleus located just anterior to the aqueduct in the gray matter of lower midbrain at the level of inferior colliculus. So at the level of superior colliculus, you have third nerve. At the level of inferior colliculus, it is fourth nerve. It is just above the pons and caudal to the lateral nucleus of third nerve. And it has mainly somatic motor neurons, and it is the only nerve to exit from the brainstem posteriorly. And because of this extra distance, we are calling it as the longest intracranial force than any of the other cranial nerves. So this is how it is. It is near the aqueductal area, the fourth nerve nucleus, and the nerve comes out, goes posteriorly, and comes out anteriorly, but it is crossing. So right-sided trochlear nucleus will give rise to left-sided superior oblique palsy. Okay, that is one thing everyone should remember, that it is contralateral supply. So because it is crossing at the level of posterior part of the midbrain. So cranial nerve 4 terminates on the superior oblique muscle on the side opposite to the nucleus of origin. In a nuclear lesion of the fourth nerve, the contralateral superior oblique muscle is weakened. Whereas if it comes out and if the nerve gets affected in any of the cisternal part, it will be ipsilateral fourth nerve, superior oblique involvement. Okay. You can see here the fourth nerve nucleus is there, and then it comes out, courses behind the midbrain, and then comes out like this. So, and it traverses through the lateral wall of cavernous sinus, then through superior orbital fissure, innervating the superior oblique muscle. So because of this, what superior oblique involvement, you will get diplopia. That will be what kind of diplopia? It will be vertical or oblique diplopia. That is impaired depression of the affected eye. And that affected eye will be hypertropic. Okay. And the diplopia worsens on the down gaze because the eye is not going down. Eye is remaining up because of superior oblique involvement. Depression is impaired, and diplopia becomes worse when you're trying to look down. And adapted position. Okay. So see, for example, this is the most difficult part of the fourth cranial nerve. One thing is that there is an oblique diplopia. Remember this. There is impaired depression, and the eye remains hypertrophic, and diplopia worsens on looking down an adducted eye. In the beginning only we had discussed that. So recti are best checked in abduction, but oblique are best checked in adduction. So if superior oblique palsy is there, it will be best tested in the adducted position. Okay, it will be best tested in the adducted position. So hypertropia increases on the head tilt to the paralyzed side. That is positive Wilczewski test. And diplopia worsens on the, if that is what the diplopia worsens on the ipsilateral head tilt. So for example, now leave this slide, but just imagine yourself that patient, you have a right superior oblique palsy. Okay, you are not able to look down because when you look down, you have a diplopia, which is a vertical diplopia. Okay, and then you try to look to the left side. If you have a right superior oblique palsy and you are trying to look to the left side, your diplopia will increase because the right eye is now going into the adducted position. Okay. So whenever the eye is moving to the affected eye, that is superior oblique palsy affected eye, when it tries to look to the other side, the eye goes in adduction, right eye, and you get a worsening of diplopia. Now, same way, if you have a right superior oblique palsy, okay, if you rotate your head or you turn your head to the right side, if you turn the head to the paralyzed nerve side, then the diplopia will increase. That is why the compensatory tilt is on the opposite side. Okay. And one more thing that happens whenever there is a superior oblique palsy, that is normally when you tilt your head, for example, when you turn your head to the left side, if you turn your head to the left side, right eye is up and left eye is down. Okay. And the right eye is normally right eye ex-cyclotots and the left eye in cyclotots. This is a normal phenomena. If you turn the head to the left side, the eye which is high, that is right eye, it ex-cyclotots and the lower eye in cyclotots. This is a normal phenomena. But in superior oblique palsy, the intorsion was not happening. So the eye which is high is ex-cyclototic. Is this clear?
No.
Hmm? Hello? Okay. I'll just show some figures, maybe that will help. But at least everybody has understood that this is a vertical diplopia. This vertical oblique diplopia, the eye is not going down, so depression is impaired, and the eye remains in the high up position. Okay, so it is a hypertropic eye. Okay, right eye is in the, suppose we'll just take an example of right superior oblique palsy. Okay, so in right superior oblique palsy, right eye is in the higher up position, that is hypertropic position. And when you're looking down on the right side, you are having a lot of diplopia, and diplopia worsens when you're trying to look to the left side. Is this at least clear? Yeah. Okay. So now we talk about a normal person. Okay. You just try to imagine yourself that you are sitting with head straight. Now you tilt your head to the left side. Okay. The left ear is approaching your left shoulder. That is left tilting of head. Okay. So if you tilt your head to the left side, which eye is on the higher side? Right eye. And the left eye is on the down side. Correct? So, in a normal person, when the head tilts to the left side, right eye ex cyclotots and left eye in cyclotots. Okay? And opposite happens from the other side also. Okay? But in your fourth cranial nerve, the higher eye is not in cyclototting. That function is everybody clear that right eye superior oblique has in cyclotorsion action. Okay. So if the paralyzed eye, that is superior oblique palsy happens, the right eye doesn't in cyclotort, so it remains in the ex-cyclotorted position. That is called as ex-cyclotropia. Okay. So that is what is the function of fourth cranial nerve. That is what depression and in cyclotorsion. If both of these if fourth nerve is affected, the depression doesn't happen and in cyclotorsion doesn't happen. So the eye remains high, that is hypertropic eye, and also ex-cyclotorted because the in cyclotorsion is not happening. This much at least one should be clear. And in fourth nerve, the diplopia worsens when you are trying to look to the, suppose for example, right superior oblique is there, when you're trying to adduct that eye, diplopia worsens. Okay. Is this these 3-4 points are clear? Yeah. Okay. So because fourth nerve is only these 3-4 things that you should remember. That is, one thing is that eye is up, it is not able to go down. There is a diplopia on looking down. When you're trying to adduct that affected eye, there will be more diplopia. And the compensatory head tilt will be on the opposite side. Suppose right superior oblique is there, you will have left tilt. Understand? So if you have lesions of the trochlear nucleus, okay, or the fascicles, you will have superior oblique palsy on the contralateral side because we saw that it is crossing in the brainstem. Okay. So nuclear or fascicular alone, usually isolated fourth nerve palsy is rare. In pretectal region, you can have additional vertical gaze palsy along with fourth cranial nerve. That is called as dorsal midbrain syndrome. Then if there is superior cerebellar peduncle is involved, then dysmetria on the side of the region may happen. Then if there can be involvement of ipsilateral horners, there can be ipsilateral horners or ipsilateral iono can be there. Okay, if the fourth nerve is affected in the subarachnoid space, you can get isolated fourth nerve, or there can be involvement of superior cerebellar peduncle. Or if the fourth nerve is affected in the cavernous sinus, usually it is associated with other cranial nerves. And if it is within the orbit, it is going to cause isolated superior oblique palsy. Okay. So this is is what is the localization. Now you can see and tell me which side is affected. Now what do you see? Somebody unmute and answer. Again, you can see here in the primary position also you can notice that the right eye is on the higher side. Now what you can see here, that you can see on adducting, the right eye is going much higher. So if the diplopia increases on looking to the while adducting the eye, okay, that nucleus is problematic. That function is problematic. Okay, so it will become right superior oblique pulse. Okay, intorsion you can't really examine on the simple gross examination. You need to do a fundus examination to understand the intorsion and extorsion. But in a busy OPD, if you just try to understand this, that which eye is high, that you try to see, and then you try to adduct that eye. Okay, and if the eye goes much higher than expected, then this and this you can compare. So this eye goes much higher when trying to adduct, so it becomes a right fourth cranial nerve involvement. Okay. And the head tilt will be on the opposite side. That is a compensatory head tilt. Okay. We'll come to how to differentiate between the fourth cranial nerve and the skew. Can anybody answer that? How to differentiate between the fourth cranial nerve and the skew? Somebody can unmute and answer. Okay. So basically, in skew also and in fourth cranial nerve also, you will have one eye hypertropic and other eye will be hypotropic. Okay. There is no much differentiation happening there. One eye is hypertropic, other eye is hypotropic. Then what else can help? So in fourth cranial nerve, the eye which is high will be, patient will not be able to encyclotort that eye, correct? Okay, in fourth cranial nerve, the higher eye is not able to encyclotort, whereas in skew, the higher eye will be able to encyclotort. That is the only difference. Because in fourth nerve, there can be one eye hypertropic, other eye hypotropic. There can be head tilt on the contralateral side in both, in skew also and in trochlear also. Head tilt will be on the opposite side. Okay, then in fourth nerve as well as in the skew deviation, the Wilczynski test may come positive. That is the diplopia worsening on the higher eye. Then, so only thing that helps to differentiate is encyclotorsion. So in fourth cranial nerve, the encyclotorsion will not happen. In skew, encyclotorsion will happen. And when you try to make the patient supine or you make them change the position, the fourth cranial nerve will not change. The eye will remain in the same position. Whereas in skew, the eye may become normalized. It's like a viewer. Okay. So in viewer, the supranuclear things, skew is a pre-nuclear condition. So in viewer, supranuclear conditions will become normal. So in these cases, in fourth nerve, the position changes don't happen. The eye will remain hypertropic. Whereas in skew, if you make the patient lie down, the eyes will come to same level. Okay, so these two are the difference. One is encyclotorsion and other one is changes with the position. Okay. Then we come to sixth cranial nerve. Sixth cranial nerve is lying present in the mid to lower pons, in the gray matter of dorsal pontine tegmentum in the floor of fourth ventricle, and it is encircled by the looping fibers of the facial nerve, and it is coming out from the pontomedullary junction, crosses the internal auditory artery, and then ascends the clivus in the prepontine system, traverses the Dorello canal between the posterior clinoid process and petrous apex. So I'll just show it over here. So this is the nucleus of sixth nerve. This is this is the seventh nerve, which is actually facial nerve. This is the internal genu of the facial nerve. This is the sixth nerve nucleus, and the sixth nerve comes out from the pontomedullary junction out. Here you can see it comes out from the pontomedullary junction, traverses the Dorello's canal. Okay, Dorello's canal is between the posterior clinoid process and the apex of the orbit, and then it traverses through the lateral wall of cavernous sinus, then superior orbital fissure, and then the lateral rectus. So if there is a involvement of abducent nucleus, if there is involvement of nucleus here, okay, so what do you expect? There can be horizontal uh, uh, eye movement will be affected. There can be involvement of nearby PPRF giving rise to gaze palsy. Okay, so what is a Foville syndrome? Foville syndrome is ipsilateral sixth and seventh and Horner, and ipsilateral deafness and loss of taste, the facial sensation, and contralateral ataxia. So it is ipsilateral sixth, seventh, that is lateral dectus, facial palsy, Horners will be there, ipsilateral deafness will be there, loss of taste and facial sensations also because of involvement of spinal tract of trigeminal nerve, and because of involvement of middle cerebellar peduncle, there can be contralateral ataxia. Okay, that is a Foville syndrome. And Raymond syndrome is ipsilateral sixth and contralateral hemiparesis. There is a difference between these two syndromes. Okay, sometimes there can be people say combined Raymond-Foville syndrome, but there is a difference. In Foville, along with sixth, there is seventh, Horner's, ipsilateral deafness, and loss of taste and facial sensation, and contralateral ataxia. Whereas in Raymond, it is ipsilateral sixth and contralateral hemiparesis. Okay, what is Miller-Gubler syndrome? It is involvement of abducent fasciculus in the anterior paramedial pons. It is causing sixth palsy, seventh palsy, and contralateral hemiparesis. So you have to remember 3, 4 only. Okay, and when the Dorello's canal is affected, petrous apex, that is, it is sixth nerve, deafness, that is sixth nerve palsy, deafness, and sometimes facial pain can be there. That is Gradienevos syndrome. And in cavernous superior orbital fissure, there can be multiple cranial nerves involvement. So now, can you tell me the localization of this? Can anybody answer? Now,
Ma'am.
can anybody tell?
Yeah, ma'am. Ma'am, this seems to be like a strabismus kind of thing, ma'am, because when the patient looks laterally, he's able to do the movement. So lateral rectus movement is intact. However, in the cover uncover, there is esotropia in right eye.
Yeah, so when you see a primary position eye, you can see that there is a right eye esotropia.
Esotropia.
isn't it?
Yes,
When you
ma'am.
keep the patient in the primary position, you can see right eye esotropia. Okay. See, right eye esotropia is there. Okay. And when you do the cover uncover test, this eye tries to correct it. The eye which tries to correct it has the esotropia will be having long standing lateral rectus. Okay. Esotropia can happen in the long standing lateral rectus. Okay, so this is a cover test positive. Whichever side it is positive, that cranial nerve is affected. That side, the cranial nerve is affected. Remember that. Okay. Now, so this patient has second nerve and sixth nerve. Where do you localize this? Seventh is not there. It is sixth and second nerve. Bilateral second optic nerve and sixth left sixth. Where do you localize? If somebody has a bilateral vision loss and there is a sixth cranial nerve involvement. Bilateral vision loss and sixth cranial nerve involvement. Left sixth. Yes, it is raised ICT. How can you have a localization where there is a bilateral vision loss and only sixth on one side? If it was a orbital apex syndrome, see, if there is superior orbital fissure, the second nerve doesn't get affected. It is at the orbital apex where the second nerve or along other cranial nerves that get affected. So second nerve along with other external ophthalmoplasia can get affected at the level of orbital apex. Superior orbital fissure doesn't have optic nerve involvement. Cavernous sinus doesn't have optic nerve involvement. Okay, so if somebody who has both side optic nerve involvement, you can't really localize it to cavernous sinus or superior orbital fissure. If you want to say orbital apex, that is also okay. But in apex, if you cannot just have second and sixth cranial, you will have other cranial, third, fourth, etc. or V1, V2. Okay, so this patient, she has bilateral vision loss and left sixth nerve. Now this bilateral vision loss, patient looks a little bit obese. So this could be raised ICT because of IH and giving rise to sixth cranial nerves. Okay, so it's a false localizing sign of sixth cranial nerve. Okay. Now this one, can anybody answer this? Yeah, somebody can answer this one. Anybody? No answer? Again, try to see. Here, what is happening? So she is not able to abduct both the eyes, correct? On both sides. The right side also abduction is not happening. Left side also abduction is not happening. But along with that, you can also see that there is eyelid depression when the patient is trying to abduct the eye. So what is that called as? Duen's retraction. Okay, so it's a bilateral Duen retraction. Okay. Again, you can see here. Now, when she's trying to look to the right side, this abduction is not happening. And so this is bilateral Duen retraction. Okay. So in right third nerve palsy, you can get complete ptosis. How do you differentiate from the third nerve ptosis and the Horner's ptosis? Third nerve ptosis can be complete or partial, but in Horner's, it is partial ptosis and elevation of the lower eyelid. This is very important. Here you can see the elevation of the lower eyelid is also seen. That is only giving rise to enophthalmos. And you in the myasthenia, you can get bilateral ptosis, but it is asymmetric. Whereas in mitochondrial myopathy, you can get bilateral ptosis, which can be symmetric. In thyroid diseases, you can get bilateral eyelid retraction. And in the plus minus syndrome, you get one eyelid ptosis, other eyelid compensatory retraction. It's a compensatory lid retraction. And in Collier syndrome, that is posterior commissure involvement, you can get bilateral lid retraction. Okay. Can you tell, and can anybody tell this localization? Patient has bilateral ptosis. So patient has no eye movement happening in any of the position, and he is trying to demonstrate VOR. Whenever you have impairment in the elevation or depression or adduction or abduction, always try to do VOR. VOR will help it differentiate from the cranial nerve involvement from the supranuclear involvement, that is gaze palsy. So if somebody has up gaze palsy or down gaze palsy, then VOR will improve that. But if somebody has superior oblique involvement and inferior rectus involvement or superior rectus involvement, then it will not improve with VOR. Okay, so it is intranuclear or nuclear lesions will not improve with VOR, and supranuclear will improve. So this patient, there is no improvement with VOR. So most likely it is multiple cranial nerve involvement. Now this patient has come with asymmetrical bilateral ptosis, left more than right. So most likely this is myasthenia with fatigable ptosis. Okay, so we have discussed with diplopia. If there is a, whenever you are taking the history of diplopia, if somebody says the horizontal diplopia, then you have to know whether it is a lateral rectus involvement or if it's a medial rectus involvement. In lateral rectus involvement, the false image will fall on the temporal field, and in medial rectus involvement, the false image will fall on the medial nasal field. Okay. And in lateral rectus involvement, the diplopia is for the far objects, whereas in medial rectus, the diplopia is for the near objects. Okay. So this is about vertical misalignment. Again, this is a very complicated thing to make somebody understand on the PPT. But you can see when the right, you can just see 3 steps. Okay. Just forget about this. So if somebody who has a right hypertropia, okay, weak muscle is either of the 2 depressors of the right eye, that is inferior rectus or superior oblique, or involvement of 2 elevators of the left eye. You can do it on in your own eyes. Just imagine if somebody is having right eye hypertropia. Either there is involvement of the superior oblique or inferior rectus of that side, or there is involvement of the elevators of the other eye, that is inferior oblique or superior rectus. Okay. Now, if I try to adduct my right eye, okay, and the eye goes high up, that is if the deviation is greater on the looking to the left side, okay, then in this position, either there is involvement of the right superior oblique or left superior rectus involvement. Okay, just forget about left superior rectus. If the adduction worsens the hypertropia, it is that eye ka superior oblique involvement. Okay, and if the deviation or diplopia or the hypertropia further worsens on right head tilt, that is ipsilateral head tilt, then it is a right superior oblique involvement. Okay, this much you should remember. That is what is Bilchowski head tilt test. Okay. So that is why if there is a right superior oblique involvement, there is a compensatory left head tilt. Okay. So what is OTR? Normal OTR, 3 components you should remember. Okay. In OTR, there is a skew. First is this, that you should remember. There is a skew, there is a head tilting, and there is a altered subjective visual vertical. These 3 components you should remember. Now we come to what is encyclotorsion and excyclotorsion. So you can see normal OTR, okay, in normal ocular counter rolling phenomena, the left head tilt, right eye will excyclotort and left eye will encyclotort. If there is a left head tilt, the upper eye will excyclotort and lower eye will encyclotort. But in those patients who have ocular tilt reaction because of involvement of utriculo-vestibular pathway, ocular tilt reaction happens because of involvement of utriculo-vestibular pathway. In that situation, the right eye will not excyclodot. It will cause encyclotorsion, and left eye will be excyclodotted. Okay. Just remember, OTR will have skew, they will have head tilting, they will have altered subjective visual vertical, and normal encyclotorsions doesn't happen. Okay. So whenever a patient comes with a diplopia, you have to ask whether it's a monoocular diplopia or a binocular diplopia. Then you have to ask whether there is a horizontal vertical diplopia, whether it is near vision or far vision, whether there is worsening in the morning or evening, whether it is there is tilting of one image seen, or whether there is associated any headache, history, fatigue, weakness. These things you should ask. Okay. So these syndromes you have to just remember before going for the exam, because it is difficult to remember all these syndromes. Claude syndrome is ipsilateral third and contralateral ataxia because of involvement of third nerve fascicles and red nucleus of superior cerebellar peduncle. North-Nagel is ipsilateral third and ipsilateral ataxia. Again here third nerve and superior cerebellar peduncle. Weber's is third nerve and contralateral hemiparesis. Benedict is third nerve and contralateral chorea because of involvement of red nucleus. Rest of the syndromes we are aware. Okay. Fifth nerve and Gradnico is fifth and ipsilateral sixth and seventh cranial as well. And in foveals, it is ipsilateral sixth and seventh and contralateral ataxia, ipsilateral Horner, ipsilateral deafness, and ipsilateral impaired taste and facial sensations. Okay, so now we come to, it is very difficult to cover all these cranial nerves. We come to second cranial nerve. Okay, now in the second cranial nerve, whenever the light falls on the cones and rod photoreceptors, okay, ultimately it passes through the horizontal and amacrine cells to reach the retinal ganglion cells. And from there, the retinal nerve fibers start. They form the arcuate bundles, which are respecting the midline raphe and enter the optic disc from the superior and inferior side. Okay. So then the optic nerve fiber exits through the globe, and optic nerve passes through the lamina cribrosa. Okay. So here you can see that there is a light falls on the rods and cones, then there are horizontal cells, then bipolar cells, amacrine cells. Finally, it comes on the ganglion cells, which give rise to axons for the optic nerve. And then the retinal macular bundles are there, which enter through the enter into the optic nerve, and then optic nerve passes through the optic canal, scleral canal, and then it continues as a optic chiasma. Okay, so this is the pathway for the, basically you have to remember, if there is a horizontal field defect, it has to be from the retina. If there is a complete blackout in one eye, it has to be in the optic nerve. If there is a vertical field defect, then it has to come from the chiasma and beyond that. Okay. So if there is a horizontal field defect, it is retinal. If there is complete blackout in one eye, that is one optic nerve. And if there is vertical splitting or vertical field defect, it has to come from the chiasma and beyond. Okay. So if there is, here you can see the left optic nerve involvement, one left eye complete black. If there is involvement of the optic nerve at this localization, then you can get a junctional scotoma, that is complete vision loss or a scotoma, complete vision loss in one eye and ipsilateral eye, and the other eye there will be scotoma. So then chiasma, you can have binasal hemianopia or involvement of midline chiasma. It will give rise to bitemporal hemianopia, and bilateral lateral chiasma involvement will give rise to bitemporal hemianopia. Left optic tract will give rise to right homonymous hemianopia. Left lateral geniculate body will give rise to sectoronopia. Here also, whether it is anterior choroidal artery or whether it is a posterior choroidal artery. In anterior choroidal artery, if there is involvement of infarction of anterior choroidal artery, it will give rise to sector sparing hemianopia. Whereas if it's a posterior choroidal artery, it will be sector involving hemianopia. In temporal lobe, it will be superior hemianopic defect. In parietal lobe, it is inferior hemianopic defect. In left occipital lobe, it will be upper bank is going to give rise to inferior quadrantopia and lower bank is going to give rise to superior quadrantopia. And tip of the occipital lobe, you can get only just scotomas at the macular level. Okay. So basically, this is most important thing when your patient comes with a vision loss. Okay, first you have to see if it's a monocular vision loss or a binocular vision loss. Okay, then if it's a painful or a painless vision loss, if it is a sudden vision loss or if it's a progressive vision loss. Okay, and you have to see the field effect. Of course, you have to see first we have to see the visual acuity. Why visual acuity is important? Because visual acuity goes down only in optic nerve involvement. Okay, if it's a field effect, you will not have poor visual acuity. So that is what I'm going to discuss here. So this is what is important. So if there is a retina involvement, okay, the color perception is blue that is more affected than the red. Okay, and you will have various horizontal field effects. Okay, altitudinal field effects. You can have some micropsia, metamorphopsia. Okay, and pupillary light reflex will remain okay in this. Okay, then in optic nerve, the visual acuity goes down. Okay, here the red color is more affected, color perception wise. Okay, and here the pupil will get affected. There will be relative afferent pupillary defect. In optic chiasma, again the same way, the visual acuity may go down. Okay, and you may get RAPD. Okay, or you may also get sometimes the both eye optic atrophy in the other eye. In optic tract, you will start getting hemianopia. Okay, so you will have a normal vision. Visual acuity will be okay. Here in the contralateral affected eye, you will get a impaired RAPD. Why? Because temporal field is affected in the contralateral eye. In everything beyond optic chiasma will have a normal visual acuity. It will be only the field effect. And the pupillary light reflex will also be okay beyond the optic tract. At the level of optic nerve, only the RAPD might be seen. Okay. And the calcarine cortex, also the vision will be, acuity will be normal. Okay. And pupillary light reflexes will be normal. And one more thing you have to remember is whether the field is congruent or non-congruent. Okay. So if it's in the tract or a temporal lobe or a parietal lobe, usually it is non-congruent. But if you go to the occipital pole, you will get a congruent hemianopia, homonymous hemianopia. Okay, so these are the rules for the visual field perception. Lesions of the retina and optic nerve produce visual field effect in the ipsilateral eye only. Only a lesion of the optic chiasma causes true bitemporal hemianopia. Retrochiasmal lesions, they produce homonymous field effects. Anterior retrochiasmal lesions produce incongruent homonymous field effect. Posterior means occipital lobe will give rise to congruent homonymous visual field effect. Temporal lobe, incongruent, and no unilateral homonymous hemianopia does not reduce any visual acuity. So whenever you are examining the second nerve, you have to first check the visual acuity, which can be done by a crude method like finger counting methods. And then you can go to color vision testing by red saturation or Ishihara charting. In contrast testing, you can use a Sloan chart. There is a field of vision, that is confrontation testing, then fundus examination, and then pupillary light reflex and accommodation reflex. Here you can see and tell me where is the localization. Yeah, first lady and second lady. Can anybody tell? If you see carefully, the right pupil was dilating uh, instead of constricting. That is what is RFPD. Okay. So these are the causes. Basically, I won't discuss all these things because we have to. One thing you have to remember is whether it is a painful or a painless vision loss. Okay, so if there is a painful vision loss, the one thing is it could be corneal lesions or it is acute angle closure glaucoma or uveitis or iridocyclitis, even optic neuritis, endophthalmitis or arthritic ischemic optic neuropathy. These are the causes of the painful vision loss, unilateral. And painless, everything posterior, retinal detachment or vitreous detachment or CRA or CRVO, usually, and non-arthritic ischemic optic neuropathy. These are the causes of painless vision loss. And then you have to know the causes of sudden and the progressive ones. Right. So sudden bilateral vision loss without progression is stroke or ischemic optic neuropathies or pituitary apoplexis. Okay, and if it's a progressive vision loss, it could be because of optic neuritis or anterior visual pathway compression like tumors or thyroid eye diseases, Leber's hereditary optic neuropathy. Okay, even the and one more thing is to remember whether it is a papillary edema or optic neuritis. So papillary edema usually doesn't cause vision loss immediately. At the onset only, if you have a vision loss, it is less likely to be because of papillary edema, that is raised ICT. It could be because of optic neuritis. Okay, so if these things are clear, that is one thing is horizontal field effect will always be seen at the level of retina. Vertical field effect will be seen in cases of optic nerve onwards. And visual acuity never goes down in cases of lesions beyond optic tract. Okay, and pupillary light reflex also is only impaired at the level of optic nerve or at the max at the chiasma. Uh, uh, After that, the pupillary light reflex remains okay. In retina, it is a blue light that is perception is affected. In rest of the lesions, it is red eye perception that is affected. Okay, and the congruence and non-congruence hemianopia, that is also very important to know. Just you have to brush up through the pupillary light reflex and accommodation light reflex pathway. Can anybody tell the difference? Difference between the pupillary light reflex and accommodation light reflex? Pathway of the pupillary and accommodation reflex. So pupillary light reflex pathway, it is through the optic nerve, optic chiasma, then it goes to the pretectal nucleus, Edinger-Westphal nucleus. Okay, optic nerve, optic chiasma, optic tract, and then it goes to the pretectal nuclei on both sides, and then through the Edinger-Westphal nucleus, the parasympathetic outcome comes through the oculomotor nerve, which supplies the sphincter pupillae. Okay, so this is easy to remember. That is a direct pupillary light reflex. Whereas in accommodation, what happens is that it comes to the through the optic tract, then lateral geniculate body, it goes to the occipital cortex, that is calcarine cortex, and then from there is a calcarine tectal tract. There is a corticotectal tract. This is very important. There is a corticotectal tract. Okay, through the corticotectal tract. Again, the same thing. It goes to the Edinger-Westphal nucleus, and then it goes to the nucleus for the convergence, and then it goes to the medial rectus nucleus of both sides. So only difference it goes to the cortex, and then cortex to corticotectal area to Edinger-Westphal, Edinger-Westphal to medial rectus subnucleus, and then causes the conversion. That is what is the difference. In pupillary light reflex, it doesn't go to the cortex. It goes directly to the pretectal area and Edinger-Westphal nucleus and direct reflex. Whereas in accommodation, it goes to the cortex, cortex to pretectal area, and then medial rectus subnucleus, and then convergence. Okay. So that is one difference you should remember for the direct and accommodation reflex. Then we are talking about Horner. Okay. So in Horner, pupil remains small in size. So pupillary, first we'll discuss this. So anisocoria in dim light and anisocoria in bright light. Okay. So if there is anisocoria, that means in bright light, both pupils should constrict. Okay. If one pupil is remaining dilated in bright light, that pupil is affected. It is affected either because of the third nerve involvement, it is affected because of the ADS pupil, or it is because of the pharmacological blockade. Okay. So if the pupil remains dilated in bright light, that pupil is problematic. It is because of third nerve or ADS pupil or because of the pharmacological blockade. So how do you differentiate between these three? So if you check accommodation, okay, and if the accommodation is preserved, that is accommodation reflex, that is Argyll Robertson pupil, okay, or accommodation reflex remains okay, then it is ADS pupil. So if there is a dilated pupil and it is not constricting to the light, but it is constricting to the accommodation, it becomes ADS tonic pupil. And if it is not reacting to the accommodation also, you put pilocarpine. And to pilocarpine it reacts, that means it is a third nerve palsy. If it doesn't react to pilocarpine also, it becomes a pharmacological blockade. So this is very short pathway to remember ki if the pupil is remaining dilated in a bright light, that pupil is problematic. It could be because of the ADS tonic pupil, or it could be because of third nerve or pharmacological blockade. And you check for accommodation first. If accommodation response is there, it is ADS pupil. If accommodation response is not there, then you have to put pilocarpine. If it responds to pilocarpine, it is third nerve. If it doesn't respond to pilocarpine, it is pharmacological blockade. If then we come to dim light. So in dim light, normally both pupils should dilate. Okay, but one pupil is not dilating. That means there is a inability to dilate. That is dilatation lag is happening. That is what is Horner syndrome. Okay, so if there is a Horner syndrome, that is that pupil will remain small. That pupil will remain small. That eye will be inophthalmos. The lower eyelid will be elevated. Okay, and so how do you confirm that it's a Horner? So you put cocaine, 5% cocaine, and the pupil doesn't dilate. Okay, then that confirms the Horners. Okay, then you put hydroxyamphetamine, 10% hydroxyamphetamine, and then the pupil dilates. That means there is involvement of, there is a Horner, but it is because of the first and second order neurons involvement. And if it still doesn't dilate, and you put apraculonidine and it dilates, then it is third order Horners. Has anybody understood this? So I'll just discuss what are the order of Horner system. First is hypothalamus. It goes through the first order hypothalamus. First order neuron goes to the C8T1, that is nucleus of Butch. Okay, its synapse is here. Then second order neuron starts. It goes to the superior cervical ganglion. Then it ends here. Then the third order neuron starts. Okay, and through the third order neuron goes to the ciliary nerve and dilator pupillae. Okay, so if your eye, if your pupil is not dilating in the dim light, it is a Horner pupil. Okay, you first try to put cocaine. In cocaine, it doesn't dilate. 10% cocaine doesn't dilate Horner pupil, but dilates a normal pupil. So it's not dilating. So now what you will do, you will put 1% hydroxyamphetamine and it dilates. So that means It was a Horner, but it was a first and second degree pre-ganglionic Horner. Okay. And if you put apraclonidine and it dilates, then it becomes a third order ganglionic Horners. Can you tell me which is the localization? Which eye is affected in here? From the first image also you can guess, even if you are not able to visualize the pupil. Yeah, so it's a left Horner. Okay. So we have discussed this Horner pupil and the role of cocaine, apraclonidine, and hydroxyamphetamine, and role of pilocarpine in a dilated pupil. So we discussed that if you put there is a dilated pupil and it is not reacting to the accommodation, then it is because of third nerve or it is because of the pharmacological blockade. And you put 0.062% or 0.1% diluted pilocarpine and the pupil constricts, okay, then it is a third nerve palsy. You put 1% and pupil constrict, then it is oculomotor palsy. Even the pharmacological blockage doesn't reverse with the pilocarpine. Can you tell this one? So can anybody guess? Left eye was not constricting to the light. No, just see again. This we are talking about in light. In bright light, if one pupil is not constricting. In bright light, if the pupil is not constricting, the problem is third nerve. And if the dim light, the pupil is not dilating, the problem is Horner's. Okay, this we are talking properly. We are putting the light here and still left pupil is not constricting. See here again. And you can see here there is anhydrosis of left half of face and there is a left pupil which is dilated, which is not reacting to the light properly. What do you think this is? Yeah, so this is a Ross syndrome. Okay, so here this is a Ades tonic pupil basically. Okay, so pupil which is not constricting to the bright light is either third nerve or it is Ades tonic pupil. If it reacts to the accommodation, it is definitely Ades tonic pupil. In third nerve, the reaction to accommodation also will not happen. Then you have to put pilocarpine. And if it constricts, it is definitely third nerve. If it doesn't constrict, it is pharmacological blockade. Is it clear? In dim light, if pupil doesn't dilate, normally it should dilate. If it is not dilating, it is Horner. In bright light, both pupils should constrict. If it is not constricting, there is involvement of parasympathetic, that is third nerve or Ades tonic pupil or pharmacological blockade. Is it clear now? Okay. Okay. So now we move on to fifth cranial nerve. Okay. So fifth is the largest nerve, largest thick cranial nerve. It's a mixed nerve. It has a small motor root and large sensory root. Okay. So basically all the nuclei, it is very difficult to remember, but fifth cranial nerve is easiest one, looking at the nuclei. First is the main sensory nucleus, principal sensory nucleus. Second is the mesencephalic nucleus. Third is the spinal nucleus or spinal tract of trigeminal nerve. and fourth is the motor nucleus. It is a so principal sensory nucleus. What is the function of it? It is carrying the sensations for the skin of face, muscle, mucous membrane of mouth and nose. Okay. And mesencephalic nucleus, it is carrying the proprioceptive impulses. And spinal tract of trigeminal nerve, it is carrying the pain and temperature sensation of the face. Okay. And motor nucleus is supplying the muscles of mastication. Here you can see this is the principal sensory nucleus. Okay. Then this is the mesencephalic nucleus, which is going into the midbrain. Principal sensory nucleus is in the pons, and this is the spinal nucleus and spinal tract of trigeminal nerve. Spinal nucleus, spinal tract of trigeminal carries pain temperature sensations. Principal sensory nucleus carries the touch, proprioception, and general sensations from the mucus and face. And mesencephalic is mainly responsible for the joint position, vibration, and jaw jerk. Okay, and this is a motor root, which is giving rise to a small motor root to the trigeminal nerve. All of these combined, there is a trigeminal nerve that is cisternal segment, and then this is the enters into the Giserian ganglion. In MRI, you can see how the fifth cranial nerve is situated. Okay, and it comes out at the mid pons. Okay, this is how the nuclei are situated. That is mesencephalic nucleus, principal sensory nucleus, spinal nucleus, and spinal tract of trigeminal nerve. Okay, and the fifth cranial nerve comes out at the mid pons level. Okay, so when the you can see here mesencephalic nucleus, principal sensory nucleus, spinal tract of trigeminal nerve, motor nucleus. These are the three segments, and this is the place which is called as the cisternal segment when it is just coming out of the pons. Then this is the trigeminal nerve, okay, and it enters into the trigeminal ganglion. Okay, so this is the trigeminal nerve. This is the sensory root. It enters into the trigeminal ganglion, which further divides into three branches. It is easy to understand. So, okay. So sensory portion, that is Giserian ganglion, that lies just beside the pons in a shallow depression called as Meckel's cave. It is crescent-shaped semi-lunar ganglion, and it has pseudo-unipolar sensory neurons. Okay, pseudo-unipolar sensory neurons. That means the central process enter the pons through the large sensory root, and this is I can just tell you that this is a trigeminal ganglion. This is the central process, and these are the peripheral processes. This is a pseudo-unipolar neuron. Okay, central process goes to the pons. The peripheral processes are going individually to the face. And then motor portion. See now, it is supplying the muscles of mastication. Okay, the supranuclear control of this motor portion comes from the corticobulbar lower third of precentral gyrus, then corona radiata, internal capsule, and decussets in the pons. Okay, it is traveling within the mandibular nerve. Motor portion of the trigeminal nerve is traveling through the mandibular nerve. It doesn't go through the V1 and V2. It goes through the V3, and it supplies the muscles of mastication, that is masseter, temporalis, pterygoids, tensor tympani, tensor vela palatini, mylohyoid muscles, and anterior belly of digastric muscles. Okay. Then one more important thing that you should remember for the exam purpose, that this is the division of the spinal nucleus and spinal tract of trigeminal nerve. You can see here at the level of pons medulla junction, that is lower pons and upper medulla, there is a pars oralis. Then there is below that in the medulla, there is a pars interpolaris, and lowermost is the pars caudalis. Now, the pars caudalis is mainly for the peripheral most part of the face, pars interpolaris a little bit intermediate part of the face, and pars oralis in the central most around the mouth and the nose area. Okay, so whenever there is, suppose there is a syrinx which is coming from the cervicomedullary junction. So the first part that can get affected is the pars caudalis. So that is the reason there can be central sparing like this, central sparing and involvement of the peripheral sensation of the face. Okay, this is called as balaclava phenomena. That is called as onion skin somatotropic organization. Onion skin somatotropic organization means the central part is supplied by the caudalmost area, which we discussed here, pars caudalis. Central part is supplying the most peripheral part. Then the intermedial is a intermediate part, and the oralis is in the uppermost rostral part of the spinal nucleus of trigeminal nerve. So principal sensory nucleus mainly carries the tactile and proprioceptive sensations from face. Mesencephalic nucleus is proprioception from the mastication and jaw jerk. So their pathway is different. Okay. So principal sensory nucleus is carrying the fine touch, joint vibration, and proprioception sensation, whereas spinal tract of trigeminal nerve carries the pain and temperature sensation from the face. Okay, here you can imagine that from the pons, the trigeminal nerve comes out. Then this is a Gizerin ganglion here, and from there three peripheral processes. So V1 passes through the superior orbital fissure, V2 passes through the foramen rotundum, and V3 passes through the foramen ovale. Here you can see in the lateral wall of cavernous sinus, V1 and V2 are passing through the lateral wall of cavernous sinus. V3 does not pass through the lateral wall of cavernous sinus. It comes out through the foramen ovale, carrying the motor fiber for the fifth cranial nerve. Motor fibers are not there in V1 and V2. They are only there in V3. Okay. Then again through the superior and inferior orbital fissure, you can see the V1 supply to the face, V2 supply to the face, and V3 supply to the face. You can just remember the C2, C3 area, that is angle of jaw area, because that is something which is not involved in the trigeminal neuropathy. Okay. And this area is the central area. V3 is more of this, that is lower jaw and the peripheral part. V2 is more of the cheek area. Okay. And V1 is upper part of face. Okay. So you know the muscles of mastication and jaw movements, that is lateral pterygoid, they open the jaw and push it to the sideways. Masseter and medial pterygoid, they protrude the jaw. Temporalis and lateral pterygoid, they retract the jaw. And masseter and temporalis, they clench the jaw. Temporalis mainly clenching of jaw. Masseter can cause protrusion of the jaw and clenching of the jaw. Then lateral pterygoid and temporalis, they retract the jaw. And lateral pterygoids, they also push the jaw to the opposite sides. So whenever there is a fifth cranial or motor involvement, jaw is deviated to the weaker side. That you should remember by rule of 17, that is 12 plus 5. Okay. So in 12th cranial nerve also, the tongue deviates to the weaker side. Similar way, in fifth cranial nerve also, the jaw deviates to the weaker side. Whereas in 7th facial nerve, the jaw deviates to the face deviates to the normal side. And in 10th cranial nerve also, the palate deviates or uvula deviates to the normal side. Okay. So that is rule of 17. 12 plus 5 is on the same side, that is weaker side. And in 10 and 7, it is to the opposite side. So there are three main things to be evaluated in the sensory examination. Whether sensory loss is real sensory loss or not, then which modalities are affected, and which distribution. Okay, so if there is V1, you should remember the V1 distribution. V2, you should remember the V2 distribution. Somebody who says that there is a complete facial sensation loss on one side, where could be the localization? It's only possible at two places. Entire face having a sensory loss can happen at two places. That is, one at the Gizerin ganglion, or when the nerve just comes out of the brainstem, that is cisternal area. Okay, in the brainstem it will be different, and beyond the cavernous sinus it will be different sensory distribution. All three are together in the Gizerin ganglion, or when they are in the cisternal segment. Okay. And how do you differentiate between the real sensory loss or somebody who is just malingering, or non-organic sensory loss? If somebody has a sensory loss, complete strict vertical sensory loss, then it is less likely to be organic. Okay, because in real sensory loss there is a there is a lot of midline overlap, so it can go beyond the midline also. Real sensory loss. Okay, but in for non-organic it will be strict midline. Even the splitting of vibration in the midline, on the right side it is preserved, on left side it is impaired. That doesn't happen clear cut vertically, doesn't happen in the organic, because there is only one bone and the vibrations will be carried to the other side. Also, if somebody is telling that there is a sensory loss over the forehead, but it's only up to the forehead and hairline beyond there is a normal sensation, that is also wrong. That is also non-organic, because V1 extends into the middle of the vertex. V1 extends to the middle of the vertex. Okay. And also, if somebody is having poor lower jaw sensory loss, that is also not happening, because in the angle of jaw there will be preservation, because there is supply by C2, C3 in the angle of jaw. Okay. What are the reflexes for the fifth cranial nerve? There is a corneal reflex, there is a jaw jerk, there is blink reflex, and these three are main actually: corneal reflex, blink reflex, and jaw jerk. So how do you check for corneal reflex? A cotton wool, and ask the patient to the look side, other side, and you come from behind and touch the limbus, not the entire cornea, and patient should blink. Okay. So what is the afferent for corneal reflex? It is V1 distribution, and efferent is through the facial nerve. Jaw jerk again is the afferent and efferent, both are fifth cranial nerve. Afferent is through the V3 division, going to the mesencephalic nucleus, coming back through the V3 division. Okay, so always any cranial nerve, whether it is most important localization is whether it is supranuclear, nuclear, or infranuclear, and if it is on the right side or the left side. This is the only problem, and this is the most difficult part to differentiate. If there is a jaw involvement, then suppose, for example, jaw is deviating on opening to the other side. Okay. Can it be UMN jaw paralysis? So jaw is usually bilateral supplied, but mainly contralateral. So if, for example, right hemispheric lesion is there, the jaw will deviate to the left side, to the paralyzed side. Okay. If it is bilateral UMN jaw involvement, it is pseudovulvar palsy. So you can differentiate it by checking the jaw jerk or the facial reflexes. If there is nuclear fifth motor involvement, what can happen? So in the motor nucleus of trigeminal nerve, which can get affected in the dorsal pons, there can be ipsilateral paresis or atrophy of the jaw and contralateral hemiplegia. Okay, but it is not just that. There will be ipsilateral anesthesia of face, because principal sensory nucleus is next to it. Okay, and contralateral hemisensory loss of the limb also. Okay, if it is just principal sensory nucleus involvement, suppose, for example, in the lateral pons, then ipsilateral entire face sensations can go, and paresthesia on the opposite side can happen. If it's a spinal tract or trigeminal nerve involvement, then there can be ipsilateral pain, temperature, sensory loss. So what is to be remembered actually is this lateral medullary syndrome. Okay, in lateral medulla, it is the if it is upper medulla involvement, then there can be entire facial sensory loss. Whereas in the lower lateral medulla involvement, you can get a balaclava phenomena. Okay, and in ventral pontine infarction, there can be only mid-facial sensory loss. Okay. And in why I'm talking about this? Because of the arrangement of that spinal tract of trigeminal nerve. It can only affect the pars oralis in the ventral and caudal pontine lesions. So it can only have mid-facial sensory loss. Okay. Then if the fifth cranial nerve is affected in the cisternal segment, you can have complete pain temperature loss on one side. Okay, in Giserian ganglion, you can have sensory loss of complete on one side. In Gradinego syndrome, it is sixth along with V1 plus Horner. You should remember Gradinego is V1 plus 6 plus Horner. What is Reader's paratrigeminal syndrome? It is basically Giserian ganglion and ICA. the space between the internal carotid artery and gazillion ganglion, there is a soft tissue over there. You can get a Horner and facial sensory loss or pain. Cavernous sinus and superior orbital fissure we know. Okay, and then when you have lesions affecting the middle cranial fossa, foramen rotundum, foramen ovale, you can get independent maxillary neuropathy or V3 mandibular neuropathies. Okay, what is numb cheek syndrome? That is involvement of infraorbital nerve in the infraorbital foramen, giving rise to numb cheek syndrome. And there is usually seen in this recurrent squamous cell carcinoma of the skin. Then numb cheek and limp lower lid syndrome. That is again infraorbital neuropathy in squamous cell carcinoma because of paralysis of upper lip and lower lip drooping. Okay, trumpet players neuropathy is upper limb numbness and pain because of anterior superior alveolar nerve involvement. In V3 distribution involvement, you can get ipsilateral masticator paralysis, that is jaw deviation. And jaw will be deviated to the paralyzed side in this. Okay. Numb chin syndrome, it is quite famous. This is mental neuropathy. It is lower lip, chin, and mucous membrane inside the oral cavity affected because of malignancy. It's a bad sign. That is usually it is affected because of lymphoma or CA breast or CA lung. Sometimes infections also. So trigeminal neuropathy, if it is a patient is coming with trigeminal sensory neuropathy, you should think of Sjogren, you should think of sarcoidosis, giant cell arteritis, multiple sclerosis, and diabetes. Most of the times it is Sjogren's, and sometimes you can see in MS because it involves that trigeminal route or entry point. So this is the case. So he's telling that there is a sensory loss in the lower lip and the lower jaw on the left side. Then he was hearing better in the left ear. Now you can see when opening the jaw deviates to the left side. Jaw deviates to the left side. You can see temporalis contracting here nicely. Yeah, you can see here the temporalis is not contracting on the left side. On the right side, it was nicely seen that temporalis bulk was seen. So where do you think is the localization for this now? It's not entire face, so it's not cisternal segment and it is not Giserian ganglia. And there is a motor involvement also. So it's not independent V1 or V2. It is V3 neuropathy. So it is V3 neuropathy because of involvement of, there is a structure we can see here. So foramen oval, there was a schwannoma. This patient had a schwannoma in the foramen oval sitting there, causing a V3 neuropathy. Okay. So motor involvement, when it comes, you have to think of V3 division. Okay. Then you have to check the sensory loss, muscles of mastication. Okay. All three segments together, entire face now, if there was involvement and along with that motor, then we would have thought of Giserian ganglion or at the cisternal level. Okay. But it is not entire face, it's only lower face and motor. So it is V3. Now this patient has, you can see here, redness of the right eye, and this area there is a discoloration also. Okay, patient had come with history of pain in this region, pain in the forehead region and pain in the right eye. So initially it was thought of pseudotumor, but extraocular movements were normal, and there was a sensory loss in the V1 distribution. There was, and this patient also had a skin lesion over here. This is a lepra patch. So patient had trigeminal neuropathy because of leprosy, and there was a ganglion, a retrograde ganglion involvement because of leprosy. Can anybody tell this? So he's showing that area. What is that area? Yeah, so this is a numb chin syndrome. Patient was a known case of CA prostate with metastasis to the mental branch. Okay. Now you can tell this one. Where is the jaw deviating? And there is an atrophy of the muscles of mastication here on the right side of face. What has she done wrong here? Can anybody answer that? What is she doing wrong over here?
He's touching the entire cornea, and also the hand is in front, nearly in front of the eye.
Yeah, so first thing is that she's touching the entire cornea. You're not supposed to do that. You're just supposed to touch the limbus. And also you're not supposed to hold the upper eyelid. Okay, the upper eyelid has to contract. She's holding the upper eyelid also. Okay, so this small thing you should remember, because in exam you tend to do all these things. She's holding the upper eyelid. It is supposed to contract, right? And close the eyelid. She's not she's holding it. So that is also wrong. The entire cornea is not supposed to be touched. Just limbus is to be touched, and patient can look to the other side, and you have to come from behind, not in the front. That will initiate the Meniere's reflex otherwise. Okay. Now we come to facial nerve. So facial nerve, you know that there is a facial nucleus and the nerve turns around the sixth nerve nucleus, that is facial colliculus, and also called as internal genu of facial nerve. And there are four or five major nuclei of the seventh cranial nerve. That is, one is superior salivatory nucleus, then there is a nucleus of tractus solitarius, spinal nucleus of trigeminal nerve, and motor nucleus. Most important is somatic visceral efferent, that is brachial arches, that is supplying the muscles of face, that is principal motor nucleus of facial nerve. Then general visceral efferent is usually for the parasympathetic supply. So it has a superior salivatory nucleus which passes through the chorda tympani, and it supplies the submandibular and sublingual glands. And then there is a greater petrosal nerve which goes to the pterygopalatine ganglion and supplies the lacrimal glands. So facial nerve has parasympathetic supply through the superior salivatory nucleus to the submandibular and sublingual glands and lacrimal glands. Okay, then nucleus of tractus solitarius, it is somatic visceral afferent. It carries the somatic visceral, it is carrying the taste sensation from anterior two-third of the tongue. Okay, and then spinal nucleus of trigeminal nerve, it carries the general sensations from the skin of ear. So fore nucleus, motor nucleus, superior salivatory nucleus, that is for the parasympathetic supply. Then nucleus of tractus solitarius, that is taste sensation of anterior two-third of the tongue. And then you have spinal nucleus of trigeminal nerve, that is for the skin of ear. Okay. So anatomy, I think the facial nerve anatomy, everybody is aware. It is again, seventh nerve is not pure motor, it is a motor plus sensory component. Nervus intermedius is the sensory and parasympathetic division of the facial nerve, and it is carrying the parasympathetic fibers for the submandibular sublingual gland and the sphenopalatine gland for the then going to the lacrimal glands. And everybody is aware of this, that the ventral part of facial nucleus, okay, it is taking care of the lower two-third of the face and has a crossed supranuclear control. Whereas dorsal part of the facial nucleus, it is covering the upper one-third of face and it is a bilateral supranuclear control. So facial nerve segments, one is the meatal segment when it is entering into the internal auditory canal. Then you have a labyrinthine segment. Then you have a tympanic segment, that is horizontal segment, then mastoid segments. I'll just show here. Okay, so here you can see this is with all the nuclei and all, facial nerve comes enters into the internal acoustic meatus. That is the meatal segment. Okay, then here it is traveling along with eighth cranial nerve, and then it enters into the labyrinthine segment. At the end of labyrinthine segment, it gives off a branch called as greater superficial petrosal nerve, which goes to the pteriopalatine ganglion supplying the lacrimal glands. Then comes the horizontal segment, which is beyond the geniculate ganglion. Okay, then at this level, you can get the nerve to stapedius. Then comes the mastoid segment. It starts with nerve to stapedius, then chorda tympani branch is given, which joins the lingual nerve and then supplies the parasympathetic to the submaxillary glands and also carries the taste sensation from the anterior two-third of the tongue. Then it comes out of the stylomastoid foramen and divides into the posterior auricular branch, digastric branch, stylohyoid nerve, and then you have two major divisions, that is upper part of face and lower part of face, that is cervicofacial division and temporofacial division. Okay. So facial palsy, everybody is able to understand now. Supranuclear facial, it is contralateral lower facial involvement. And you have to understand what is emotional facial paralysis and what is volitional facial paralysis. In volitional, if you ask the patient to smile, then you can notice there is a there is retraction of the angle of mouth and there is a deviation of angle of mouth on asking the command. Okay. And when the patient is crying or laughing, the both sides of smile is normal. Okay, that is volitional. On asking if there is a facial paralysis noted, that is a volitional facial paralysis. But on laughing or smiling or crying, it becomes normal. Okay. So usually these fibers, they pass through the lower precentral gyrus, internal capsule, cerebral peduncle and upper pons. Whereas in emotional facial paralysis, when you ask the patient to smile, it will be normal. But when they try to naturally laugh or cry, you can notice that there is a facial deviation. In here, the pathway is different. It goes from the contralateral striatum, globus pallidus, hypothalamus and thalamus. It does not pass through the internal capsule. So emotional facial paralysis, the pathway is different. In volitional facial paralysis, the pathway is different. In volitional, it passes through the internal capsule. That is why on command, it doesn't happen. Whereas in emotional, it is passing through the emotional structures, which are like basal ganglia, globus pallidus, hypothalamus and thalamus. Okay, it does not pass through the internal capsule. So this diagram is from the De Jong actually. When the patient is asked to show the smile, it is happening bilaterally normally. But when he is laughing, there is a deviation. So this is emotional facial paralysis. Okay. And here the patient is asked to smile and then there is a deviation happening here. Okay. But when patient is naturally laughing, it is normal. So this is a volitional facial paralysis. Okay, then nuclear and fascicular lesions. You know that entire one side of face become paralytic, loss of wrinkling of forehead, facial asymmetry, blink asymmetry, Bell's phenomena. All these things are known. Okay, so you all are aware of all these syndromes. I'll just jump to next part. Brackman staging. People should know when there is a facial paralysis, and one should always check the taste sensation when you are getting a facial palsy. You should check the taste sensation as well, especially anterior two-third of the tongue. Okay, so all the structures will have loss of taste sensation except from where the chorda tympani branch is given and the lesion is coming from that area, that is from the stylomastoid foramen onwards. If you have a facial paralysis, the taste sensation may be preserved. Okay, then I just wanted to touch upon this topic, that is aberrant corticofacial tract. So somebody has asked you what happens to the Bell's phenomenon in bilateral UMN versus in bilateral LMN, you will get bilateral Bell's. In UMN facial paralysis, you don't get Bell's phenomena. Bell's phenomena is a classical of LMN facial palsy. How to differentiate bilateral UMN and bilateral LMN? They have told one is taste sensation and also facial reflexes. If the facial reflexes are very brisk, it indicates that there is a UMN facial involvement. Okay. Then normally we know that the corticobulbar tract comes and it synapses on the facial nucleus on the opposite side. Okay. Sometimes the corticobulbar tract may descend ipsilaterally into the pons, then it goes into the medulla, and then in the lower part of medulla it crosses over and goes to the opposite side and supplies the and ends in the contralateral facial nucleus. So if there is a lesion here, there can be in the medulla, in this part of the medulla, you can get contralateral UMN facial palsy. And if there is a lesion at this part of the medulla, then you will get ipsilateral UMN facial paralysis. Okay, so usually facial doesn't happen in medulla, but in this aberrant corticofacial tract, you can get facial involvement. So this patient, I'll just show. So you are getting a Bell's phenomena, right side, right element facial. Even the platysma is not contracting on the right side. This patient, it is volitional versus emotional. Which one it is? What do you think? Yeah, so patient has emotional facial paralysis. So we come to eighth cranial nerve now. Eighth cranial nerve, I'll go in short now. There is a cochlear portion and vestibular portion. Cochlear portion is mainly for hearing and vestibular portion is mainly for the balance. So this is the cochlea, and you can see here there is, I'll just go to this structure first. So in cochlea, it is like arranged like a tree, okay? And there is a modulus in the center, and from there the osseous lamina comes out and it carries forward as a basilar lamina, okay? And then it is divided into three components by the scala, Reissner's membrane or vestibular membrane. Here there is a Reissner's membrane. So this becomes the scala vestibuli, this becomes the scala mediae, and this becomes the scala tympani. Okay, these structures that you see are the Scarpa's ganglion for the cochlear nerve. Okay, this continues and forms a cochlear nerve basically. Okay. So here you can see that there is a basilar membrane on which there are multiple cells, but you should remember inner cell and the outer hair cells, inner hair cell and outer hair cells, which are overlapped by the tectorial membrane. So it is the movement of this tectorial membrane that activates this hair cells. And from there, the nerve fibers are carried into the carpus ganglion here, situated here, and then it continues in the cochlear nerve. So cochlear, you should know first order neuron, second order neuron, third order neuron, and the fourth order neuron. So what is the first order neuron? First order neuron from spiral ganglion to the cochlear nuclei. That is the first order neuron from the spiral ganglion, this spiral ganglion to the cochlear nuclei is first order neuron. Then from the cochlear nuclei, that is dorsal and ventral cochlear nuclei are there. From there to through the trapezoid body, then through the lateral lemniscus, and it goes to the inferior colliculi. That entire thing is a second order neuron. Then from the inferior colliculus to the medial geniculate body, that is third neuron, and from the medial geniculate body to the Heschel's gyrus, that is transverse temporal gyrus, that is Heschel's gyrus, that is fourth order neuron. Okay. So you should remember first order neuron, that is originating from the inner and outer hair cells. Okay. And at the apex, there is stimulation by the lower frequency sounds, and at the base, there is a stimulation by the higher frequency sounds. Okay. Dorsal cochlear nuclei, they are carrying the afferent from the high frequency, that is basal hair cells, and the ventral cochlear nuclei are carrying the afferents from the lower frequency apical hair cells. Okay. So this is what is the auditory pathway. You should remember that is cochlear nerve, cochlear nuclei, dorsal and ventral. It crosses over into the trapezoid body, then it carries forward as a lateral lemniscus. Then it carries forward in the lateral lemniscus. It goes to the inferior colliculus to medial geniculate body, medial geniculate body to the lateral temporal gyrus, that is Heschel's gyrus. Okay. And there is always bilateral innervation. So that is why in the brainstem, if unilateral lesion happens, usually the hearing loss is not so significant. Even in the cerebral hemisphere, there has to be bilateral involvement to cause a significant hearing loss. Okay. So you should know hearing loss when you classify as a mild, moderate, severe, or a profound hearing loss. Then sensory neural hearing loss, when you have, it is usually for the high pitched or high frequency sounds. And loss of speech discrimination. These are the features of sensory neural hearing loss actually. It is for the loss of hearing of high pitched sounds and loss of speech discrimination out of proportion to pure tone deafness. Okay, so now how to test the cochlear division? That is, first is you check it by the crude method, by ticking sounds or ticking the clock. Okay, and you can know which ear is hearing less. Okay, so you should have a background knowledge that which ear is hearing less. Okay, then you can carry forward the further test, that is Rene's test. It compares the air and bone conduction, okay, of the patient himself. So first you put the tuning fork on the mastoid, and when the patient is no longer hearing the sound, then bring the fork towards the external auditory meatus, keeping 1 centimeter from the external auditory meatus. And if the vibrations are still perceived, vibrations are no longer perceived in this side, then what is it? Can anybody tell if somebody has stopped hearing the vibrations at the mastoid and continues to hear it in the front of ear, then it is air conduction better than bone conduction. Okay, so AC is better than bone conduction means either it is normal or there is a sensory neural hearing loss. But if there is a already decreased hearing on that ear and air conduction is better than bone conduction, then it is a sensory neural hearing loss. Okay. And in conduction deafness, it is bone conduction better than the air conduction. For the next test, that is Weber's test, you put the tuning fork in the midline of the skull or forehead, and then if suppose right ear hears it better, then the problem is conducting hearing loss in the right ear or the left ear sensory neural hearing loss. If somebody is hearing better in the right side, either there is a conductive hearing loss of the right side or there is a sensory neural hearing loss on the left side. That is what is Weber's test conclusion. Then Schwabach's test is comparing bone to bone conduction with the patient and the examiner. Okay. So if there is a sensory neural hearing loss, the Weber test lateralizes to the normal ear. Rene's test is positive because air conduction is better than bone conduction in the affected ear. And Schwabach test demonstrate worse bone conduction in patient than the examiner. Whereas in conductive hearing loss, Weber's test lateralizes to the affected ear. Rene's test is negative because bone conduction is better than air conduction in conductive hearing loss. Okay, so if somebody has a cerebral hearing loss, that is cortical hearing loss, it is usually difficulty that is called as pure word deafness. They have difficulty localizing sound. They can hear sounds, but they are not understanding what sounds they are, or they are not able to understand the spoken language. The written language they may be able to understand. So they will not be able to localize sounds. They will not be able to understand different pitches, and they will not be able to understand the spoken language, but will be able to understand the written language. Okay, if there is a brainstem, usually only in one condition it happens, that is ICA territory infarct. Or it can happen because of the nerve involvement in the CP angle lesions. Okay. So then we come to vestibular system. You know, the labyrinth has consists of utricle and saccule and 3 semicircular canal. Utricle and saccule is for the linear acceleration, whereas the semicircular canals are for the angular acceleration. Utricle and saccule is for the linear acceleration. 3 semicircular canal are for the angular acceleration. Okay. And you can see here that the superior part of vestibular nerve carrying the sensation from this is the superior part of the vestibular nerve. It carries the sensation from the utricle and anterior and lateral semicircular canal. So utricle and anterior and lateral semicircular canal through the superior division, and inferior division carries the fibers from the saccule, okay, and the posterior ampulla. And superior division from the utricle and anterior and lateral semicircular canal. So these superior division and inferior division combine. Okay. And so one should know also the nuclei. So semicircular canals go to the superior and medial vestibular nucleus, whereas utricle saccule go to the lateral and inferior vestibular nuclei. You should see this nuclear arrangement. That is superior vestibular nucleus, medial vestibular nucleus, lateral vestibular superior vestibular nucleus, lateral vestibular nucleus. This is inferior vestibular nucleus and medial vestibular nucleus. So what we read just now, that semicircular canal go to superior and medial vestibular nucleus, whereas utricle saccule go to lateral and inferior vestibular nucleus. Many times in the exam, the viewer pathway is asked. Okay. So just remember, when the head rotates to the right side, this figure is very easy. The head rotates to the right side, it activates the same-sided horizontal semicircular canal. That activates the ipsilateral medial vestibular nucleus. That medial vestibular nucleus activates the contralateral abducent nucleus. And also it activates the, through the medial MLF, through the MLF, it activates the ipsilateral medial rectus. So that carries the eye to the opposite side. Okay, it is very easy to remember. Head turning to the right side, activation of the ipsilateral horizontal semicircular canal, activating the medial vestibular nucleus, activating the opposite sided lateral rectus, so the eye starts looking to the other side. Also activating the ipsilateral medial rectus through the MLF, and the eye, both eyes moving to the left side. This viewer pathway is very important. Somebody can ask in the exam, how do you check the vestibular function? So at least you should know few answers. One is you are checking viewer. That is also one way to check vestibular function. The head thrust test, dynamic visual acuity. You know what is dynamic visual acuity? You shake the head multiple times and you check the visual acuity before shaking the head and after shaking the head. So there is a decline in the visual acuity by 2 points. That is dynamic visual acuity. Then you can also check by seeing the patient walking on straight line, then star walking test, so caloric test. So all these things are just to remember, this is the way you check the vestibular system. Okay, so if somebody has a central vestibular involvement or peripheral vestibular involvement, best test to differentiate between these two is doing a hints and hints plus. At least you should be aware of these two things. And also central vestibular nystagmus is always continuous nystagmus. It does not have a fatigue. There is no latency in it. And it is a pure nystagmus, pure horizontal, pure vertical nystagmus. Okay. Less vertigo and less vomiting also in central. Whereas in peripheral vertigo, you will have latency and it's a fatigable nystagmus. And also there can be mixture of nystagmus, so horizontal plus rotatory. Okay. Vertical nystagmus doesn't happen in the peripheral. Usually it is the horizontal plus rotatory nystagmus. And also about nystagmus, you should remember, if suppose right-sided vestibular pathology is there, the fast beat of the nystagmus is to the opposite side. Okay. In primary eye position, you start examining, then the fast beating is to the opposite side. But if you try to do the Dix-Hallpike test. So if you bring the head down to the right side and right vestibular system is affected, it will start producing a nystagmus, but the nystagmus fast component will be to the opposite side. So what is hints and what is hints plus that you should remember? Hints is head impulse test, nystagmus, test of skew, and hints plus will have additional vision loss. Okay, this was a good test to differentiate the peripheral versus central vertigo. But only in one central condition, the hints can be positive, which is that is ICA infarct. Head impulse can be positive in the ICA infarct, even though it is a central vertigo. Okay. So can you just tell me in this head thrust test which side is pathological? See, again, there is a see, that is the thing. If your head is taken to the right side and the catch-up circuit is happening to the left side, then the side which is, if the head you are rotating to the right side and you are getting a catch-up circuit, that is the problematic side. That is right side is problematic side. Catch-up circuit is not the side for the problematic side. So it's a right vestibular system that is problematic here. Okay, you rotate the head to the right side and you get a catch-up circuit to the opposite side. That is why the head impulse test positive, but on the right side. And hints plus you have a hearing loss. Okay. Can anybody tell this? Can anybody tell the localization? So somebody has correctly identified patient has right seventh because infrequent blinking on the right eye. Patient also has right eighth because he tried to demonstrate there is a decreased hearing on the right side. And what kind of nystagmus this was? Yeah. What kind of nystagmus this was? This was a Bruns nystagmus, isn't it? How it was a Bruns nystagmus? How it is a broad nystagmus? So it was a coarse nystagmus on the side of the lesion, whereas a fine and a fast nystagmus when looking to the opposite side. Coarse on the affected side. Okay. So this patient had a right CP angle tumor. Can anybody tell this? This is acute onset. You can see right facial is there. So this was a right ICA territory infarct. Acute onset facial and hearing loss and ataxia. So we come to ninth cranial nerve. It is not very useful as such in the clinical examination part. But there are four major nuclei. Nuclear ambiguous supplies the stylo. It's the only motor. It is the only muscle that is supplied by ninth cranial nerve, that is stylopharyngeus. It has three sensory nuclei. Three nuclei, that is inferior salivatory nucleus. That is for the parotid gland. So superior salivatory nucleus was for. Does anybody remember? We read it in some nerve recently. Yeah, seventh cranial nerve, superior salivatory nucleus. Then this also has this in that superior salivatory nucleus was for which ganglion? It was for the lacrimal also and submandibular sublingual glands, whereas the inferior salivatory nucleus is for the otic, that is parotid gland. Okay, nucleus of tractus solitarius. Basically, this nucleus is responsible for carrying all the taste sensation. So even for the seventh nerve, anterior 2/3 is going through the nucleus of tractus solitarius. For ninth nerve, posterior 1/3 is going through the nucleus of tractus solitarius. For 10th nerve also this nucleus is going to come, that is going to carry the taste sensation from the posterior most part of the taste sensation. The spinal tract of trigeminal, no, basically they are carrying the general visceral afferent, that is pain and temperature sensations. So they are carrying it from the tongue, tonsillar region, palatal arch, soft palate, and ear. Okay. By the tympanic branch of glossopharyngeal nerve, that is called a Jacobson nerve, it is supplying the tympanic membrane, and there can be Jacobson nerve neuralgia. Okay. So how do you evaluate this cranial nerve, ninth cranial nerve? Basically, posterior 1/3 of taste sensations and salivatory secretions from the parotid gland. You can't really judge from the motor examination. We'll directly go to now 10th cranial nerve. So 10th cranial nerve has one is general visceral efferent. That means it is supplying the parasympathetic supply to the glands and the smooth muscles. The nucleus is dorsal nucleus of vagus. Okay. Then you have somatic visceral efferent. Somatic visceral efferent, that is supplying the muscles of the branchial arches, that is larynx and pharynx. And the nucleus is nucleus ambiguous. So these two nuclei are very important. Dorsal nucleus of vagus is entire parasympathetic supply and the smooth muscle supply to the thoracic and abdominal viscera. Whereas nucleus ambiguous is for the pharynx and larynx, that is branchial arches. That is special visceral efferent. Then you have general visceral afferent and somatic visceral afferent. Somatic visceral afferent means taste sensation from the epiglottis and posterior most part of the tongue. Whereas general visceral afferent, it is general sensations from the thoracic and abdominal viscera. The nucleus is nucleus of tractus solitarius. And then you have general somatic afferent, that is spinal nucleus of trigeminal nerve. And that is general somatic afferent is basically skin of ear. So these are the nuclei for 10th cranial nerve, and this is the entire anatomy of this 10th cranial nerve, 4 nuclei, and the entire 10th cranial nerve, how it courses. We don't have to remember all this. So how do you evaluate the 10th cranial nerve? So first is on examination. So you ask the patient to open the mouth, and you can see the palatal position and the uvula position. Okay, the palate should be normal at rest and uvula should not be deviated to any side. Okay, and when you're checking for the uvula deviation, it is not the tip of the uvula that is important, it is the base of the uvula that is important. Okay, so when you are asking the patient, and then you are asking the patient to say ah, that is called as palatal reflex. So when you say ah, you can see the elevation of the palatal arches and you can see the deviation of the uvula in that situation. Okay, and then you can check the gag reflex by taking the swab stick, which I'll show in the next part. And sensory function, basically, it is carrying the sensations from the ear, that is general somatic afferent, and taste sensation from the posterior most part of the epiglottis. Gag reflex, and we can see whenever there is a palatal paralysis, flattening of the palatal arch, and with phonation, ipsilateral palate face to and uvula is deviated to the non-paralyzed side. Okay. So we remember 10th rule of 17, 10th and 7th, it goes to the normal side. Okay. We can see one point to note is supranuclear gag paralysis also can happen, but it is usually control is bilateral. Unilateral palatal paralysis without notable weakness of extremities can happen in the superior segment of corona radiata infarcts. And in nuclear, you can get nucleus ambiguous involvement in the lateral medullary syndrome. Why you get palatal weakness? Because of involvement of nucleus ambiguous, because that was supplying the pharynx and larynx. Okay, but in nucleus ambiguous also there are two divisions: cephalad portion and the caudal portion. So if only cephalad portion is affected, only pharynx may get affected. That is called as palatopharyngeal palsy of Abelis. And it can spare the laryngeal function. If the entire nucleus is affected, then pharynx and larynx both will get affected. So these are the syndromes. Most important 3 syndromes you should remember: Vernet, Villarret, Collet-Sicard. Okay. Vernet is 9th, 10th, 11th, jugular foramen. Villarret is 9th, 10th, 11th, 12th plus Horner. 9th, 10th, 11th, 12th plus Horner. The localization is jugular foramen or plus hypoglossal canal. Collet-Sicard is 9th, 10th, 11th, 12th, but there is no Horner in Collet-Sicard. It is again localization jugular foramen plus hypoglossal canal. Okay. Abeles syndrome is 10th cranial nerve and contralateral hemiparesis. The lesion is brainstem. Tapia is remember 10th and 12th cranial nerve. Okay, which is again peripheral. Medial medullary, everybody knows, that is ipsilateral 12th and contralateral hemiparesis. And Babinski-Nagote is combination of Wallenberg plus Dejenin, that is lateral medullary syndrome. Okay, so yeah, I'll go to next part now. So jugular foramen syndrome on Vernet 9th, 10th, 11th, Schmidt syndrome 10th and 11th, Jackson syndrome 10th, 11th, 12th, Collet-Sicard is 9th, 10th, 11th, 12th plus Horner. Horner doesn't happen in Collet-Sicard, it is happening in Villarret. So then we come to 11th cranial nerve, that is cranial plus spinal accessory nerve. So cranial part is coming from the nucleus ambiguous of medulla, and spinal is root segments from the C1 to C6. You can see here C1 to C6 rootlets, they form a nerve and they combine with the cranial root of accessory nerve, and then it comes out through the jugular foramen. C1 to C6 enter through the foramen magnum, join the cranial accessory nerve, and then come out through the foramen, jugular foramen. Okay. So it is very difficult thing to localize. Actually, if corticobulbar fibers, you should remember that the UMN fibers for the 11th cranial nerve are crossed for trapezius and ipsilateral for the sternocleidomastoid. Okay, so if there is right hemispheric problem, then you will get contralateral trapezius weakness and ipsilateral sternocleidomastoid weakness. Okay, because of double decussation for the sternocleidomastoid fibers. Okay, and in corticobulbar region, sternocleidomastoid fibers are located in the posterior part and trapezius fibers are located in the ventral part. So only ventral pontine lesion can produce paresis of only trapezius and sparing the sternocleidomastoid. So just remember, if there is a UMN 11th cranial nerve involvement, you will have ipsilateral sternocleidomastoid and contralateral trapezius involvement. And if it's a brainstem involvement, suppose if it is involving ventral pontine, then you will only get trapezius weakness and it will spare the sternocleidomastoid. If it's a dorsal pontine, you may get only sternocleidomastoid and sparing of trapezius. So everybody is aware how to check for the sternocleidomastoid. It can, both the sternocleidomastoid flex the head, and one sternocleidomastoid on the right side rotates the head to the opposite side. The face deviates to the left side and occiput is on the right side. Okay, and both trapezius, they retract the head or extend the head. Okay, and if you have trapezius and sternocleidomastoid both involvement on the same side, then what would be the localization when it comes out of the brainstem? Okay, till the brainstem, that is supranuclear, it is crossed, that is ipsilateral sternocleidomastoid and contralateral trapezius. But once it comes out of the infranuclear part, it is same set sternocleidomastoid and trapezius. Okay, this is what I have tried to describe it over here, basically. Now tell me, what is the localization? What is the localization? You can clearly see there was a right Horner's and there is a right bulbar weakness. So it's a pica infarct, basically, right pica infarct. Okay. So this is the way you check the palatal reflex or gag reflex. Take a swab stick, check independent right and left palate separately. But you can see there is a very exaggerated gag reflex. It is seen in the ALS case. And in the cases of trapezius or 11th cranial nerve, you can get wasting of the sternocleidomastoid and trapezius on the one side, and the trapezius may be deviated out and laterally. And last cranial nerve, that is 12th cranial nerve, that is hypoglossal nerve arising from the medulla. And important part, it is pure motor and comes out of through the occipital condyle. And it also joins the ventral rami of C1, C2, C3, which gives rise to superior root of ansa cervicalis. And this is the inferior root of ansa cervicalis. Okay. Hypoglossal nerve comes out of the medulla in the medial part of the medulla. So you get a Dejerin syndrome because of involvement of medial medullary syndrome or heart in brain syndrome, we call it. So ipsilateral tongue and contralateral hemiplegia. Okay, so tongue is again supranuclear control. It is contralateral, and the major muscles are genioglossus and hypoglossals and styloglossus. Palatoglossus is not supplied by the 12th cranial nerve. Okay, it is supplied by the 10th cranial nerve. And then there are intrinsic muscles of the tongue, that is horizontal, and there are transverse, horizontal, vertical muscles, intrinsic group of muscles. Genioglossus, what is the function of genioglossus? It draws the root of the tongue forward and protrude the tip. Anterior fibers depress and retract the tongue and draw it back into the mouth. And mainly you should remember, when you're checking the tongue, when you're asking the tongue to protrude, the deviation happened to the paralyzed side because of the unopposed action of the contralateral genioglossus muscle. Okay, so you can just see this video. So what do you think is the localization for this case? You can also hear the voice is hoarse. Can anybody answer? It is 12th cranial nerve. Along with that, there is a hoarseness of voice. So there is involvement of 10th cranial nerve as well, right? So there is a 10th and 12th cranial nerve. The localization goes to, this is like a Tapia syndrome basically. Tapia syndrome. Okay, there is no long track sign in this patient. So it has to come from the out of the brainstem. Okay, the localization is the Tapia syndrome, jugular foramen, or sometime in the retropharyngeal space. So here, this is the retropharyngeal space of the patient where there is a nasopharyngeal carcinoma. Okay, now you can just see this case. You can see the tongue is leading to the right side now. So it is a right 12th cranial nerve patient and no other signs. And patient had just suboccipital region pain. So localization is occipital condyle syndrome. Patient had a granuloma in the occipital condyle. Uh, can anybody localize this? Anybody? So can anybody just tell the nerves that are affected in this? You can see here clearly there is bilateral facial involvement and tongue is wasted and tongue is fasciculating also. Yeah, so this is element type of anterior console involvement. Okay, so this patient turned out to be fasciolontis syndrome. That is LMN facial and bulbar weakness. No UMN involvement. Okay, so tongue, just remember ipsilateral deviation and the syndromes associated with the 12th cranial nerve. Supranuclear control, you know, tongue deviates to the side of hemiparesis, that is away from the lesion. And there can be medial medullary syndromes because of the vertebral artery involvement. The tongue is towards the side of the lesion, which is away from the hemiplasia. Infranuclear, you know all these syndromes. There is something called as Gord-Fridson syndrome, which is 6th and 12th cranial nerve involvement. And the localization is to clivus because of nasopharyngeal carcinoma or malignant METs. Occipital condyle syndrome, you can have pain and ipsilateral nerve involvement. Then these syndromes we discussed. And last is first cranial nerve. I'll just show the anatomy. Here, these are olfactory cells. Hello. 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 Yeah, so we were on the last part of the actually slide. Is it visible? Yeah, okay. So you can see that the medial olfactory stria, and then there is a lateral olfactory stria. Lateral goes to the paraolfactory piriform lobe, and medial goes to the anterior commissure. And basically, we were discussing about the lesions causing about anosmia. So local nasal diseases like allergic rhinitis or polyposis, or involvement of these nerve filaments by the head injury, or olfactory naming or recognition can get affected because of involvement of orbitofrontal and anterior medial temporal lobes. Okay, then disturbances in complex olfactory function, despite relatively preserved detection of odors, can be seen in alcohol, that is Wernicke-Korsakoff syndrome, because of involvement of thalamic or prefrontal cortex lesion. Olfactory dysfunction is seen in PD and sometimes in AD as well. And in MS also you can have olfactory dysfunction. I think for how you should just know how to test the olfaction. So basically, how do you check the olfaction? Can somebody unmute and tell? How do you check the olfaction?
Hello.
Just last thing we'll discuss how to check olfaction and how to check taste.
Hello. So,
Yeah,
ma'am, we test it individually for each nostril.
yeah.
We close one nostril at a time and then
Mm.
give patient to smell like coffee bean or perfume or a soap bar,
Mm.
and then on the other side also.
Mm. That is
And
for
eyes
the smell
closed.
sensation. Yeah.
Yes, ma'am.
And for the taste,
For the taste, we hold the tongue and we test sweets or bitter. The sweet is at the tip, the bitter is at the posterior aspect of tongue, and the sour is on the sides.
hmm. But how does the patient answer? Because you have hold the
Ma'am,
tongue, you
he'll
have to keep the tongue.
Yes, ma'am. So we'll ask the patient to close his eyes before testing.
Huh? And once the eyes are closed
And
and you
then,
are holding him, how will he answer?
Mm,
That means you have never checked it. You have to make the flashcards, okay, or placards we say. So sweets or sweet, sour, bitter, all these flashcards you can make, or even you can name it like this is salt or this is coffee, okay. And you have to show that flashcard to the I mean, the patient is told that this is one is sour, two is bitter, three is salty, like that. And patient has to close eyes, and you are putting holding the tongue, and you are putting the objects on the tongue, and patient has to remember and tell one or two or three. Okay, he can point it like
yes, ma'am.
one or
Yes,
two, like that. Understand? So that is why taste sensation, some examiner may just find amusing to ask you how to check the taste and how to check the smell sensations. Okay. Especially if there's a PD case, you should check the smell fast, like in a rapid examination. Okay. I think that's it, sir, from my side. Hello? Any questions? Okay, thank you. Bye.
There are any questions? Okay, if there are no questions, we will conclude the session. Thank you, Dr. Swaleha, for presenting this session. We'll conclude. Thank you, everyone.